Good morning, everyone. I'm here just to talk for about 10 minutes, and our remit was to try and introduce the various subgroups of the clinical studies group. I chair the Rehabilitation Sub Group, and I took over the leadership of this group from Andrew Wilcock, and in its previous guise, this was the cachexia subgroup and a breathlessness subgroup, which merged into a broader rehabilitation title. I'm a physiotherapist by background and have undertaken lots of studies which involve asking patients and people affected by cancer and other chronic diseases to undertake physical activity programs to try and incorporate exercise as part of their treatment package. And that can be anything from the patient that's newly diagnosed trying to maintain their gym routine whilst they're having radiotherapy treatment, for example, or shortly after their surgery trying to recover with quite a vigorous program of exercise, to someone very close to the end of their life, often a number of weeks, trying to work on the very transfers from bed to chair or getting around the house that will keep them that little bit more independent and perhaps prevent them from coming into formal care services. Rehabilitation is, like supportive care, a very broad term. Rehabilitation isn't just recovering from an acute illness. It got its brand really post-war, where there was lots of recovery and regaining independence after the traumas and the injuries gained from war. Rehabilitation isn't just recovering from an acute ankle sprain or an injury. It isn't just talking about physical function. So whenever I say function, this means someone's existence, someone's ability to participate in their daily living and in the world, not just physically, but also psychologically, emotionally, spiritually, and so forth. It's about how much that person can gain from each day. It's also not just about regaining function, and often the aim of rehabilitation in the context of advanced cancer in particular is about maintaining someone's function, or perhaps just slowing down the decline in someone's function, which might be an inevitable consequence of their cancer and its treatment, particularly where there's metastatic disease and curative treatments aren't being sought towards their cancer. There are lots of similarities between the concept and the definitions of rehabilitation and with palliative care and supportive care. The overall goal, the sole purpose of treatment is to improve someone's quality of life. And it's about being active, and it's about living as productively and successfully as possible. Both of these specialties, or all of these specialties, are based on needs rather than someone's diagnosis. We're principally interested in what bothers you the most. What's the thing we can try and help you with, as opposed to letting people in or stopping people at the door because of a diagnostic label. Our care is also provided irrespective of someone's prognosis, and so there's no requirement for rehabilitation, for supportive care or for palliative care for someone to be expected to live for a certain number of months or years or weeks. Everyone can participate and benefit from rehabilitation. The family is really the unit of care, and so often family members are involved in helping people remain independent at home, and it's a very holistic approach to care. And the unfortunate thing, or the challenging thing in rehabilitation and in supportive care, is many of the interventions that we develop and many of the interventions that we test are complex. And that means there's lots of different parts to each treatment or each intervention that's being tested. Different parts apply to different people and different settings, and so what any one patient gets in the context of a trial might vary depending on that particular situation, whether they're on or off treatment, how able they are to engage in exercise type activities, and more importantly, their preferences and their goals of that care. People come in a gym setting, people come for different reasons. It might be to get fitter or stronger, it might be to get some social participation, it might be to get some respite from their family who are perhaps driving them mad at home, perhaps they're driving the family mad at home. It's a space to link with a group of people and engage in a shared activity. And the interventions are often problem solving and quite pragmatic in their approach. And there is, of course, this managing of people's expectations, helping people to adapt and coping with people's expectations so far as their hope. The rehabilitation subgroup was formed a couple of years ago, and as I said, it's amalgamated from these breathlessness, fatigue, and cachexia subgroups, which historically existed. Excuse me. And our remit is to explore interventions to maximise patients' ability to function, again in this broadest sense, to help people adapt and to help people to stay independent or as independent as possible for as long as possible. And there's a particular focus on the physical aspects within our subgroup. This is slightly purposeful, and because in the NCRI there's a psycho-oncology clinical studies group, to try and avoid complete replication of efforts, we've decided to focus predominantly on physical aspects of function and physical consequences of cancer and its treatment. But this is by no means exclusive. There is, of course, lots of overlap. We're not narrow-minded in the sorts of symptoms and the sorts of issues we're trying to deal with our interventions. And similarly, at the present, there's a focus on the shorter-term consequences of care, because in the psycho-oncology clinical studies group, they're seeing people who are seeing late effects of treatment that Sam showed in his slides, perhaps 5 or 10 years after a cancer has been cured. I'm going to run through just a few studies which have come out of the rehabilitation subgroup and its the older working groups as well. Cancer cachexia, excuse us, a spelling error, is a complex problem. This is about someone having an abnormal metabolism. It's costing them more energy to exist each day, and also having a reduced food intake, a poorer appetite, or taking on less food. And this is the reason why lots of patients with cancer present with weight loss and often lose their muscle tissue and lose their fat. And that has lots of adverse effects for their treatment, for their symptoms, how symptomatic the patient is, how well they can engage in anti-cancer treatment, and how well they can function in the world. It was previously a very nebulous term and trying to encompass everything. My PhD was on cachexia prior to this definition, and towards the end was only the sort of first time there was some agreement between the academic community of what this syndrome was and how we could define it and get a gauge of how big the problem was. But the group, many people from the cachexia subgroup and others internationally have clarified the cachexia criteria, and this is someone who's lost 5% of their body weight over 6 months, someone with a slight frame, a BMI of less than 20, who have lost less than 2% of their weight loss, or someone with sarcopenia. This is a loss of muscle, people with a frail look or low muscularity, and again who have lost some of their weight. And importantly, this arrow along the bottom shows that there was a recognition of different stages of cachexia. And while some people are in this dark grey area towards the black arrow, and they have quite advanced cachexia, they've lost lots of their weight, they're very impaired functionally, are very symptomatic and hard to treat. It's certainly not something you could reverse as a syndrome in that setting by definition. There's also a group of people towards the left-hand side of the slide in that light grey area who we would define as having pre-cachexia. So these are the very people at the point of diagnosis who are at high risk of losing their muscle and losing their function during their cancer treatment. And with these people, we can be a bit bolder in our approach because they've got the capacity physically to engage in sorts of exercise programs that we hope would build muscle and hope would help people function better. They can engage in quite intensive nutritional programs. Often when you're offered nutritional supplements, the reality is you need quite a lot to take in if you're hoping to gain muscle tissue or maintain muscle tissue. So you need a fairly well-functioning, low symptomatic patient group to engage in those sorts of interventions. And this definition has really had international recognition and has been accepted worldwide, specifically in the field of cancer. There are other definitions for other conditions, but for cancer, the subgroup's really taken ownership of this unifying definition. This one, I'm sorry, is probably for more the academic audience. If you haven't read this paper and you're in cancer care, then you really should. It's in the Journal of Clinical Oncology. And it's really hard empirical objective data on the impact of weight loss and the impact of a low BMI on death and survival. So in the top left corner, these are the absolute numbers of people in each of these cubes. There's a 5 by 5 cube. There's over 18,000 people in this study, and when they report how much weight they've lost, and when they have their BMI assessed, which is as simple as measuring someone's height and weight, we can tell fairly starkly the impact of those two things on that person's survival. So the top right is the people's median survival for each of those squares. The bottom left is their hazard ratios for survival. So people in that bottom right corner of each cube have got 3 times the risk of dying than the person in the top left. And there's a scoring system in the bottom right there. So this has got really important implications at both ends, actually. At the point of cancer treatment, where someone presenting with weight loss and someone with a slight or low BMI is at greater risk of symptoms and at greater risk of deteriorating towards death. And at the other end, it's important because hospices now are reaching out and very much offering supportive care and very much offering exercise and rehabilitation programs. And as well as people who are close to death accessing hospice services, there are many people who have a survival of a year or more. And we can identify those patients who are coming into hospice outpatient services who are actually well functioning. They've not lost some weight, or if they have, they've regained it after their successful cancer treatment, and they've a build which would allow them to engage actively in daily living. And these people will likely be around for some time, and we can ask more of them in our rehabilitation programs. Another study we did, which was quite interesting, looked at measuring people's activity levels. How much people do on a day-to-day basis. And you can stick these fancy pedometers onto people's legs. They walk around with them for a week. They're very lightweight and small. And they can tell us how much time that person spent on their feet, how many steps they took each day, the sorts of activities they engaged in, and how much energy they expended. A really person-centered outcome measure. If we say what we want to do with our treatments, often it's allowing people to do more and to become more active. And this allows us, there was a study which came from the Rehabilitation Sub Group. Across many centres in the UK, we asked patients to wear these monitors. We established that they were acceptable to use in the context of research studies. We gathered data to say how to measure physical activity by this way, and the sorts of outcomes which are important and psychometrically in the context of a research study are quite robust and should be used in future studies. And again, this has been taken up. The last example of a study is this, which is a muscle stimulator. This is a form of exercise by any sort of national or international definition, and it focuses on people's thigh muscles, which are important to get people out from a seat up into standing. They're important when we walk around, and they're important when we do activities to stay at home, the stairs, stair climbing, toileting, getting into standing from sitting, etc. There are more useful forms of exercise that will offer greater benefits so far as getting someone stronger, but the reality is lots of people can't engage in intensive exercise programs that require time and travel to commit to. So this is something people can potentially do at home and can get strengthening benefits from to help them in their functioning. And there are lots of data around this sorts of intervention which demonstrate even in people who have advanced and metastatic disease, you can offer them this type of intervention to do at home. They will get stronger if they engage in a program. And if their strength is limiting how much they can exercise, then people's exercise capacity, their ability to do walking and whole body activities improves. The current portfolio is in the booklets that we have, but roughly speaking, we've got some exercise and self-management programs, studies around different symptoms and their etiology, and studies which examine different types of functional assessment. And one of the strengths of the group is that we've got lots of multidisciplinary expertise and people who are used to measuring aspects of function, like physical activity level, like exercise capacity, and we can bring those to other clinical studies groups. And the last slide is that we're very much, like all subgroups and like all CSGs, open for business. So we really encourage people to get in touch. We're happy to mentor, we're happy to have partnerships with other members. We're really happy to provide advice and support on other people's study ideas or research advice generally. And importantly, lots of the work that we do specifically is high on patient agendas and high on service users' agendas. The issues that come up when you ask the public what they want to work on, what their highest needs are often the very things that we're working on as a subgroup. Thank you.